thank you very much, and thank you, Gary, for that kind introduction. And certainly I want to thank the Vasculitis Foundation for having this wonderful symposium and for having me here to be a part of this. It's a tremendous privilege, and I will always be tremendously grateful for everything they do in support of people with vasculitis, and certainly in supporting our research and training efforts. And as I say, it's really a pleasure to be here just to give back in a very small way for everything that they do. Again, it's also an honor to be here today to discuss with you about some of the research that's taken place over the past 2 years. And as you will notice, I will stretch just a little bit outside that on certain occasions. And to try and put in perspective a little bit about what we have learned in a very short period of time, and what does this mean for people moving forwards. And one of the things I just wanted to step back and think about a little bit is I think that all of us come to the table with a little bit of a different view about what research is and what this means to us. And if we really think about it, everything we have learned about vasculitis really came about as the result of research, whether that was the very first description of a form of non-infectious vasculitis, the initial use of cortisone or prednisone at the Mayo Clinic, the first time we recognized that there were multiple forms of vasculitis, and as Peter and Gary alluded to, as far as the first description of the use of Cytoxan by Drs. Fauci and Wolf, the description of ANCA, the first multi-center or comparative trials in vasculitis, and then the first FDA-approved medication. And really, research is the process through which we gain answers to questions that are important to us. And also, as our role as investigators is not only to perform the studies and look at the results, but then to ask, what is the next question we have to ask, and be able to take those to the next level. And because of that, research can really ask many different questions about the process of diagnosis, the course of a vasculitis over time, the very difficult decision we face sometimes in determining whether vasculitis is active, what we recognize that is very important as far as what affects all of you as far as the quality of life related to vasculitis. Certainly how we could prevent recurrences, how we develop better forms of treatment and reduce those side effects, and then as some of the exciting things that Peter Grayson and others are doing as far as really understanding what are some of the causes of vasculitis that may be occurring. And ultimately, well, how will understanding all of these questions lead to what all of us want, which is a cure of these diseases. Now, also, as Peter mentioned, there are many different forms of vasculitis, and these don't occur in individual silos. There is basic research as far as where we think about things within the context of the laboratory. And there's also what we refer to as clinical research, where we take those advancements and try and look at new forms of treatment and how that applies as far as to people. And of course, this is a spectrum which includes in there the idea of translational research and biomarkers. And what happens as far as when we're trying to do the studies we do is we take those investigations and results that we find within the laboratory and apply those to clinical research. And in turn, we take the results from clinical research and ask, what is that telling us within the laboratory? And again, Peter gave you some really excellent examples about how that's been done within the context of some of our larger studies. Research can also be performed in a variety of different settings, all of which are important. And this includes research that's being done within a single center or facility, and this is laboratories that are taking place throughout the world. And also it's important, as you've heard throughout this symposium, as far as the work of collaborative research, where particularly for uncommon illnesses like vasculitis, we come together to have enough information from enough people. And this is work that's taking place both at the level of states, countries, continents, and certainly across the world internationally. So a lot of exciting work has been done in vasculitis. And if we look at PubMed, which is sort of the Google for doctors, and we look about the term vasculitis over the past 2 years, there have been over 6,000 publications on the topic of vasculitis. Now, of course, 6,000 articles are going to be very difficult to cover in a 30-minute period of time. So what I hope to be able to try and do for you is to provide you with some examples of recent studies examining clinical research in different forms of vasculitis so that we can really highlight for you the diversity of research that has been and is ongoing, that as research is taking place really in all forms of vasculitis, and that these are studies that are being performed all across the world. So I do want to start with the topic as far as granulomatosis with polyangiitis and microscopic polyangiitis. And in 2013, as you've heard throughout the course of this symposium, we tend to think about the treatment of these diseases in terms of the severity of disease and the concept as far as initially controlling disease, which we call induction, and then maintaining that control, which we call maintenance. And of course, one of the more recent advancements has been the description of rituximab. And we know since the publication of the RAVE and RituxVash trials in 2010 that rituximab very much deserves a place on this diagram as a medication that is effective for the treatment of GPA or MPA. However, the next questions that this immediately rose is, what about the issue about relapses after rituximab? Should we give repeated courses, and what about the long-term safety? So over the past 2 years, there were 2 articles that were published in the same journal of one of our major rheumatology journals, Arthritis and Rheumatism. This was one that was conducted at the Mayo Clinic, and the first author was Dr. Carton Seba, who you heard from at this symposium. And the question that this study asked was, what was the experience in their institution with people who had GPA or MPA who received 2 or more courses of rituximab? They described 53 individuals who received a collective course of 233 courses, and this ranged from people who received 2 courses to one individual who received up to 12. And what they learned from the study was that rituximab can be used at repeated intervals and remains effective over time, but relapses did still occur, and watchfulness for side effects remains important. So the next question, of course, this research raises is, can there be markers identified to guide rituximab retreatment? Should we be giving rituximab at set intervals? And do safety issues emerge with rituximab over longer term, even longer than what was seen in this study? Now, the other study that was published in this same journal was from the United Kingdom. And what this question asked was, they observed what the experience was in the people they cared for that had GPA or MPA who also received rituximab. And they looked at 2 different periods of time, the period from 2002 to 2006, where again there was still a very early emerging experience with rituximab, and they gave 1 course and observed those people over time. And then they also looked at their experience from 2006 onwards, who received a course of rituximab initially and then followed this every 6 months for 2 years. And what was learned from the study was that rituximab does still have an association with relapses. Now, with repeated dosing every 6 months, the relapses appeared to be less, but still occurred, particularly after this was stopped. So the questions these raises, is 6 months the optimal interval for rituximab to be given? How does rituximab compare potentially to other maintenance agents that we use, such as methotrexate or Imuran or Cellcept? And is this repeated scheduling safe over an extended period of time? Now, one of the things we also recognize is that GPA and MPA don't all behave the same, and it does have a severity spectrum from people who can become very ill with this, who people still have problems, but the disease is less severe. And the question we've had as far as particularly for people who have non-severe recurring GPA or MPAs, are there treatment options that may be suitable for us to consider? And during the time that we were asking this, there was a medication that was introduced that focused on a cell within the immune system called the T cell. When T cells in our immune system are in the process of causing inflammation, they go through a process that's called activation. And this is one of the steps that may occur in inflammation occurs. During this time, there was a medication introduced for the treatment of rheumatoid arthritis that's called abatacept or Orencia, and how this works is that it blocks this process of activation, so T cells may not go on to cause the inflammation that's present. So the question that we asked is whether abatacept is safe and effective in people who have non-severe relapsing GPA. This was a study that was conducted by the Vasculitis Clinical Research Consortium in 20 people that again had non-severe recurring GPA, and we followed them over time for their response. The results from this study were encouraging in sustaining remission and allowing people to come off of prednisone, and the safety experience was good. But the limitation is that this does remain a small experience, and it's what we refer to as an open label study, where all of the people received this treatment and were followed over time. So the next question this really raises is that with further experience, will we see similar encouraging results in GPA? And again, this remains a very early experience such that we would not be using this in practice at the current time. Now, I do want to shift at this point to eosinophilic granulomatosis with polyangiitis, or EGPA, and focus on a study published just this year from the French Vasculitis Study Group. This was a very large study conducted in EGPA, and they really sought to look at what are the main characteristics in a large group of people over time, and how has this changed. And this was a review of 383 people who were seen all the way from 1957 to 2009. The features of the illness were, as we have seen previously, as far as a high rate of asthma with vasculitis affecting the nerve, the skin, a high degree of involvement of the ENT areas, the lung, and also the potential for heart involvement. And we also saw that vasculitis relapses occurred in about 1/4 of people. Also, as we had also seen previously, only about 16% were able to come off of prednisone. But gratifyingly, we also saw that improved outcomes were seen over time. So people nowadays were doing much better than when these were seen back in the 60s and 70s. But the question this large experience raises is, are there treatments for EGPA that can help to reduce relapse and prednisone requirements that these individuals have? And one of the things we know about this illness is one of the cardinal cells that's present is the eosinophil. This is a normal type of white blood cell that we all have in our bloodstreams, but these are found in increased numbers in EGPA. If we look at this diagram as far as the eosinophil, one of the things we've seen within the laboratory is that an inflammatory protein that's called interleukin-5 or IL-5 plays an important role in the eosinophil biology. And when it's exposed to this inflammatory protein, there are a number of things that happen with the eosinophil. They survive for longer, they multiply, and they also become activated and start to do more activities. Well, there has been a medication that has been developed called anti-IL-5 or methylismab, and how this works is it blocks this protein such that these activities that occur in the eosinophil do not happen, and thus all of these things that can go on to cause inflammation are reversed. This medication has been looked at in a couple of different studies. This first one was conducted in the United States in Boston and assessed whether methylismab allowed prednisone reduction in people who had prednisone-dependent EGPA. They treated 7 individuals with 4 doses of methylismab that was given once a month. And what they found was that this medication reduced the eosinophil count and allowed a prednisone reduction in all people. But after stopping the medication, the EGPA features returned, requiring prednisone bursts. The interpretation of these results, though, must be regarded with some caution because, again, 7 people is not a large number to be able to look at, and they were also followed over a short period of time. But the question this raises is whether, with further experience, will we see similar encouraging results over time? Now, a more recent study that's also been looked at from Germany, and then there was a recent update in 2012, also evaluated this medication for remission induction in people who had relapsing and refractory EGPA. They treated 10 individuals who received 9 doses of the medication once a month and then who switched to methotrexate. 8 of these people achieved a remission and were able to go to a prednisone dose of 0. Their eosinophil counts also went down and the safety was good. None of these people had a relapse while they were on methylismab, but after stopping this and switching to methotrexate, 6 people relapsed. Once again, though, even 10 patients is certainly a very small size, and we have to be careful as far as how we interpret this. So both of these studies really, again, raise the ultimate question about whether methylismab is safe and effective in EGPA, and additionally, both of these really used it for a fairly short period of time, raising about how long would it need to be continued in order to be effective. Now, I want to shift now to tokyosu arteritis. And as we know from studies, including this one conducted at the Cleveland Clinic by Kathy Maximowicz-McKinnon, although tokyosus can effectively achieve remission in about 93% of people, unfortunately achieving a sustained remission of at least 6 months and a tapering of prednisone dose less than 10 milligrams daily occurs in a relatively small proportion of patients. So we'd like to have options that would be able to achieve better approaches. One of the things that certainly is a striking finding in this illness is the presence of a type of inflammation called a granulomatous inflammation. And from studies that we've learned in other human illnesses and also in mouse models, one of the proteins that has been seminal to these granulomas occurring is a protein called tumor necrosis factor, or TNF. And this binds to receptors that are present on the surface of different types of cells within the immune system. There are medications which are called anti-TNF agents, and then some examples include infliximab, which is also called Remicade, or adalimumab, also called Humira, that bind to the surface and block these TNF receptors so they can't bind to the surface of the cell. So the question was asked was, can medications that impact this TNF protein provide benefit in tokyosu arteritis? Now, this is a very long list of studies that have been done dating back to 2004 with a study that Dr. Hoffman did that really have examined this medication in different small numbers of patients with tokyosu arteritis. And I do want to just focus on 2 of these that were done that involved the largest number of people. In the first study that was done by Eamon Malloy at the Cleveland Clinic, they examined what the experience was at our institution with anti-TNF therapies in people with tokyosu arteritis. And this was a description of 25 patients who had difficult to treat tokyosu who received an anti-TNF treatment. What was found was that 88% had a remission and were able to reduce their prednisone to less than 10 milligrams a day. And 60% were actually able to come off of prednisone. 16% did still experience a relapse, and 16% also had side effects, but this was an encouraging, although not definitive, study. And this raises the question about, with further experience, will we see similar encouraging results with other anti-TNF agents in tokyosu? There was another study that was also published from the Mayo Clinic in 2012 that also examined their experience with anti-TNF treatment in 20 patients who also had difficult to treat tokyosu, who were followed for up to 39 months. 90% of these people achieved remission, and 50% again also had that remission for over 6 months at less than 10 milligrams of prednisone. 33% relapsed in this study, which again was for a longer period of time, and 20% had side effects. So once again, encouraging but not definitive. So both of these studies, as well as the whole collective experience with these medications, raise the question still about whether anti-TNF therapy is safe and effective in tokyosu arteritis. Now, switching to giant cell arteritis, I think, again, frustratingly for many people with this illness, if we examine the current treatment in 2013, whether it be for severe or non-severe disease, the treatment approach consists of prednisone and prednisone. So we know that prednisone is effective, but unfortunately it does not prevent relapses, and as we all know, it has a tremendous number of side effects. So what is the next question? We need options beyond prednisone. One of the things, again, we have observed in studies within the laboratory and trying to understand this illness better is that there is an inflammatory protein called IL-6 that has been of long-standing interest in GCA, dating back to studies conducted in the 1990s. And IL-6 has been found in giant cell arteritis tissues, such as temporal artery biopsies. The IL-6 is a protein that binds, once again, to a receptor present on cells. And there has been a medication that has been used in rheumatoid arthritis called tocilizumab, which is an anti-IL-6 receptor. So again, how this works is it binds to this receptor on the surface of cells, so this IL-6 can't bind and do its inflammatory activities. So since this relatively newer medication was introduced in rheumatoid arthritis, it has been asked about whether this can provide benefit in giant cell arteritis. And one of the things to emphasize is, although there have been some reports dating back to 2008, the total number of people from all of these collective studies has been extremely small, 23 published to date. What was learned from this experience was that although overall a beneficial response has been observed, interestingly, there were 2 reports that found active vasculitis under the microscope despite this treatment, such that the effectiveness of tocilizumab in GCA is currently unknown. So the next question is, of course, this experience raises is whether this is effective and whether this is safe. This is a medication that does have some associated side effects potentially relevant in older individuals that we do need to consider safely and consider in caution. Now, I want to switch from GCA, a disease of older individuals, to Kawasaki disease, a disease of the youngest of our children. And this is a form of vasculitis that does occur almost exclusively in children. And one of the complications that is up to 1/4 of patients who do not receive treatment will develop these aneurysms of the coronary arteries, the arteries of the heart. Interestingly, Kawasaki disease is treated with a medication that's called intravenous immunoglobulin, or IVIG, and it's one of the few forms of vasculitis in which prednisone is not routinely given. But one of the ongoing questions in the pediatric community has always been whether there is any role for prednisone in Kawasaki disease. This was a study conducted in Japan and published in the journal Lancet that asked the question about whether prednisolone combined with this IVIG reduced the risk of these aneurysms in the heart arteries in children who have had what is called severe Kawasaki disease, or where they are predicted to have a high likelihood of resistance to this IVIG medication. This was a comparative study in which 125 people received the combination of IVIG and prednisolone, and they were compared to 123 that just received the IVIG alone. What they found was that the occurrence of these aneurysms was less in the people that had, again, severe Kawasaki disease who received the combination therapy, and this did provide support that these resistant patients may benefit from the addition of a prednisone or steroid-containing medication. The limitation of this study, though, is that the tool that was used in this study to be able to predict those individuals that might have this more resistant pattern to the IVIG has interestingly not been found to predict this resistance outside of children in Japan. So the next question this study raises is whether there can be tools that can be developed to develop these patients who may be at higher risk and who might benefit from this type of approach in all populations that have Kawasaki disease. Now, cryoglobulonemic vasculitis is, again, another uncommon form of vasculitis that we can see. And cryoglobulins are these proteins that appear in the blood upon cooling, and we can see these sort of settling in this tube of this blood that's been spun down. One of the associations that we can see with cryoglobulonemic vasculitis is the infection of hepatitis C, and it's believed that this is responsible for 70 to 85% of cryoglobulonemic vasculitis. And if we look at what occurs in this setting, we have the hepatitis C virus, a protein that binds to this in response to when this infection is present, and then another protein that occurs also over time called rheumatoid factor. And it is all of these together that actually make this cryoglobulin that you can see settling on the bottom of this tube. If we look at this schematic as far as how cryoglobulonemic vasculitis might occur, again, we see here this cryoglobulin that, again, within this blood vessel wall can cause vasculitis. And we can see all of these individual parts coming together. The hepatitis C that's made in the liver, the binding protein, and then we can see the development of this rheumatoid factor. And one of the intriguing parts of sort of this schematic has been The fact that these B cells, again, which we know are a cell that are responsive to rituximab medication, whether this can make a difference in disrupting this pathway. So if we were to remove this rheumatoid factor, we can see that the cryoglobulin can no longer be present to potentially affect the blood vessel and cause vasculitis. So this was a medication that was examined in 2 different studies that were also again published in Arthritis and Rheumatism in 2012. The first was from the National Institutes of Health that asked the question about whether rituximab could be effective in people who had hepatitis C-associated cryoglobulonemic vasculitis who could not take medications directed towards their hepatitis. This involved 24 people who were treated with rituximab either now or in 6 months period of time. And they found that the people who were treated with rituximab did much better than those who received this at a later period of time. This was well tolerated and did not worsen the hepatitis infection, and it provided support that rituximab was an effective option for those people who were not able to take hepatitis C treatment. But it did raise the question about whether all people should receive rituximab and should it actually be combined with antivirus treatment to be more effective in that way. Now, there was further experience that was also published with this medication from a study that was conducted in Italy. And what they asked was whether rituximab was more effective than conventional treatments in this illness. This involved a study of 57 people. 28 received the rituximab and 29 had the more conventional treatments. And again, these are things like prednisone, Cytoxan, Imuran that you're familiar with. Once again, rituximab appeared to be more effective than those who received the conventional therapy and was also well tolerated. So it did provide support that rituximab is an effective option as compared to our conventional treatments. This does raise the question, though, about in what setting we should still consider conventional treatments and where should rituximab be placed within the sequence of our treatment options as far as how to approach this illness. Now, a final disease I wanted to touch on was Bichettes disease. And Bichettes disease is a complex illness that can have many features, and one of those involves blood clots that occur within the veins, or venous thrombosis. And this can occur in anywhere from 15 to 39% of people and can be serious in some instances. And again, we can think of blood clots that may occur in the legs or even in veins that can occur in places such as the veins of the head. Blood clots are traditionally treated with blood thinners, but a question in Bichettes disease is whether clots should also be treated with medications that suppress the immune system and the inflammation that may be occurring in these veins and contributing to the clots. This was a study that was conducted in France, which examined what the long-term outcome of clots within the veins is in people who have Bichettes disease. And they examined the outcome and treatment experience of 586 patients who had venous thrombotic events. 33% had at least one clotting relapse. Almost all of these patients did receive blood thinners, but the addition of prednisone appeared to prevent clotting relapses. Other immunosuppressants also prevented clotting relapses, but the limitation of this type of study is it is based upon a past experience. So this is again what we refer to as a retrospective study, which always we have to view with some caution. This does, though, raise the next questions about what is the role of blood thinners in this setting, and is the combination of immunosuppressants such as prednisone or other medication plus blood thinners beneficial in this setting. So as we reviewed some of this research today, some of the important questions that you may have had in going through this is why are some of these studies that I presented today encouraging but not definitive? And I've referred to a couple of different times as far as different types of studies that we do. All of our studies will begin at a starting point that often may involve small numbers of individuals and that will lead to the development of larger scale studies over time if those results have been beneficial. So these retrospective and open label studies are not definitive, but they are important in allowing us to see whether a treatment should be examined in a larger scale study. Why is it that there are studies sometimes that we do where the medication did not work? And despite our best efforts and our best rationale scientifically, the reality is that not all of our studies will result in positive results. That does not make them any less important, and knowledge is always gained from every study, even the negative ones. Also, one of the things you might ask, as far as I presented a lot of different experiences across a lot of different forms of vasculitis with a diversity of medications, and will results from one study in one form of vasculitis apply to another? And the answer is in general no. Results don't directly apply across different types of vasculitis. However, what we learn in one form can benefit other forms as far as advancing our knowledge and thinking about where we go in terms of these next questions and next steps. So in terms of the question I was asked to review today, what is new in vasculitis and what it means for patients, what I hope you've seen today in terms of the diversity of research that's taking place and the results that are coming through is that the future is very bright, and we've seen some very exciting developments that occur that will lead to, I think, even further excitement for the future. Research advances have been made in diverse forms of vasculitis from studies being performed all over the world, and by working together, we will continue to make discoveries that will benefit all people with vasculitis. So thank you very much, and it's a pleasure to be here today.